Our speaker, Dr. Anandita Kulkarni. I'm so happy she's from Plano, Frisco. Yay! Who's from Plano, Frisco? Woohoo! Dr. Kulkarni is a world-renowned speaker in the field of preventive cardiology and lipidology. Her clinical experience and expertise is in the management of complex lipid disorders, women's cardiovascular health, and South Asian cardiovascular health. With over a decade of experience in this field, Dr. Kulkarni has authored numerous articles and published in several journals. She's also an active member of the American College of Cardiology and American Heart Association and National Lipid Association, and also sits on several committees. She currently serves as an assistant professor at Texas A&M College of Medicine. She's also the medical director for the Center for Cardiovascular Disease Prevention at Baylor Scott and White, the Heart Hospital in Plano. Please welcome Dr. Anandita Kulkarni. Thank you for that introduction. Bear with me while I pull up my slides here. So it's great to kick off this morning's talks while everybody is fresh and caffeinated. I'm a little biased, but I do think that prevention is not only the first intervention, but the most important intervention. And before I start off with my talk, I'd like to introduce the concept that health is more than the absence of disease. And a lot of the medicines that we prescribe are really to treat disease, not to optimize health. Optimizing health is an investment that we need to make into our own lifestyle. And so I always say preventing heart disease, or disease in general, is a way of life. And so today my talk is going to address different aspects of optimizing cardiovascular health, primarily in the South Asian community. So we've all heard it over and over again that heart disease is the #1 killer in both men and women. When we look at cardiovascular disease prevalence, we see that it remains the leading cause of global mortality and is a major contributor to disability worldwide. South Asians make up about 25% of all humankind, about 2 billion individuals. This graph here shows the percent change in age standardized cardiovascular disease death rate from 2010 to 2019. And while the global prevalence of cardiovascular disease actually continues to increase, the greatest increase is seen among South Asian countries. We're also a community on the rise. We are one of the fastest growing minority groups within the United States. And because of that, it's imperative that the health needs of the South Asian community are critically examined for a variety of reasons. First, we need to ensure culturally appropriate medical and health services. We need to address a variety of serious health conditions that are faced by the South Asian community, create informed policy decisions, and finally, improve current and future research in this group. Within medicine, representation also matters. Asians are the majority of the minority workforce across most domains within medicine, and roughly 2 in every 5 cardiologists is Asian. This is our community, this is the people that we take care of, and we need to learn how to advocate for them. So there are a number of unique barriers when accessing healthcare for South Asians, many of which you may have also seen in your practices. So the first is cultural. Existing cultural attitudes, fear or stigma of a diagnosis, stigma of taking medication, maybe even mistrust in Western medicine. Financial, the lack of health insurance, high out-of-pocket expenses for appointments and prescriptions. Health literacy is a big one. South Asians can have poor health literacy despite being a very well-educated group of individuals. And this sometimes may be difficult to tease out and a challenge that we need to address in our clinical practices. Communication, such as language barriers, and finally, discrimination and racism. I'm sure that many of us have experienced racism and discrimination, and so do our patients. And it's important to note that this is associated with poor health and poor cardiovascular health. So when we look at South Asian cardiovascular health and the risk of cardiovascular disease, the overall risk among South Asians is higher. However, this risk also varies by country of origin. While the overall cardiovascular disease risk is roughly twofold for South Asians, it is as high as 4 times in Bangladeshis and 3 times in Pakistanis compared to non-Hispanic whites. The prevalence of coronary disease is also higher at the same age compared to local populations, with the curves beginning to diverge around the age of 40 to 49 years. There are a number of risk factors that contribute to heart disease. These include hypertension, diabetes, high cholesterol, elevated lipoprotein a family history of heart disease, smoking, obesity, a sedentary lifestyle, and an unhealthy diet. And we're going to talk through some of these during my talk today. The American Heart Association came out with a concept called Life's Essential 8, which outlines 8 metrics to optimizing cardiovascular health. And we're going to touch on these during the talk today, but refine some of the guidance a little bit to individualize this to our South Asian population. So I'd like to start out with discussing diabetes. South Asians are 4 to 6 times more likely to have type 2 diabetes than the general population. The Masala study is a large prospective study of South Asian individuals and found roughly a 23% prevalence of type 2 diabetes. There's also differences in the prevalence of diabetes depending on where you're from, so North Indian versus South Indian versus Pakistani. What is more telling is that the prevalence of pre-diabetes in the Masala study is at 60%. And this certainly represents a red flag with regard to the risk of transitioning on to the development of diabetes. So we asked the question, what contributes to the high prevalence of diabetes within the South Asian community? One thought is that there's predisposed genetic susceptibility due to impaired insulin secretion. When you look at non-diabetic South Asians, they had poor insulin secretion compared to other racial groups. Compared to other race and ethnicities, non-diabetic South Asians had increased insulin resistance, decreased beta cell function, and decreased insulin secretion. Next is our diet. I'm going to dive into this a little bit more. But in general, animal protein, fried snacks, the sweets, the high-fat dairy that are included in the South Asian dietary pattern include foods that are high in saturated fats and trans fats, all of which negatively impact glucose metabolism and insulin resistance. When it comes to physical activity, South Asians fare far worse and on physical activity metrics compared to other populations. Data from Masala shows lower metabolic equivalents per week among South Asians by about 30 to 50% less compared to other groups. Also, body composition can contribute to this. So even at a lower BMI, South Asians can have increased central obesity, ectopic fat, and lower overall lean muscle mass. Let's talk about body composition a little bit more. When we look at body mass index recommendations for South Asians, they are lower than that of non-Asians. Recent data suggest that even a BMI of 23 may be too generous. The data in this graph show that a BMI of 19.6 in South Asians would be equivalent to white men and women with a BMI of 25 with respect to the prevalence of 2 or more cardiometabolic risk factors. Recommendations from the NICE guidelines and American Diabetes Association suggest lower population-specific BMI ranges
such that a BMI of 23 or greater should trigger screening for diabetes. So the key point here is that South Asian individuals develop risk factors, cardiometabolic risk factors such as diabetes at a lower body mass index. And this really needs to be identified among our patients so that appropriate screening can be done. So once again, when we're thinking about screening for diabetes, we would do it at a lower body mass index, particularly with a cutoff of 23. Let's talk about dyslipidemia. A higher risk of atherosclerotic cardiovascular disease is attributed to low HDL cholesterol levels and high triglycerides. One of the most common phenomenon that you may see in our patients who have diabetes is something that we call diabetic dyslipidemia. Elevated LDL cholesterol, elevated triglycerides, and low HDL cholesterol. Lipoprotein A is another risk factor for heart disease that is starting to gain traction. We've known about lipoprotein A for the past 40 to 50 years, but only recently have we really started to talk about it. Elevated lipoprotein A is an independent and causal risk factor for atherosclerotic cardiovascular disease. It is proatherogenic, prothrombotic, and pro-inflammatory, and is associated with disease in many different vascular beds, leading to myocardial infarction, ischemic stroke, atherosclerotic stenosis, and even aortic valve stenosis. Despite knowing about elevated lipoprotein A for such a long period of time, there are actually currently no pharmacologic treatments that are clinically available at this time, though several are currently in development. This is a really interesting study that was published in the JACC. When you look at the relative atherogenicity of lipoprotein A versus LDL cholesterol particles, you find that even though LDL particles are much more abundant than lipoprotein A, and carry the lipoprotein A particles carry the greatest on a per particle basis. Lipoprotein A particles carry the greatest proportion of cardiovascular disease risk, and Lp(a) is about 6 times more atherogenic than LDL. So when we look at the global prevalence of elevated lipoprotein A, approximately 20% of the world's population has elevated lipoprotein A. The LPA gene was identified in Africa and migrated out across various migration tracts throughout the world. When you look at South Asians, approximately 25% have elevated lipoprotein A. And knowing that this is a potent driver of heart disease, it's important that we screen all of our patients for elevated lipoprotein A to see if we can mitigate the risks of this over time. When it comes to tobacco use is a preventable risk factor, and we've actually seen a downtrend in the use of tobacco. However, the prevalence among Asian subgroups varies, with an estimated prevalence of approximately 7.6% in South Asians specifically. However, there is a little bit of a gap when we assess for tobacco use. So traditional questionnaires and screening tools may actually underestimate the use of tobacco products. And there are a number of cultural and traditional tobacco products that may be more commonly used that are missed on traditional screenings. So it's important to ask about product-specific questions that can reveal higher rates of alternative tobacco use compared to standard questionnaires. These include the use of hookah, zarda, gutka, and things like that. So one of the important questions to ask when screening your patients. Let's talk about diet. This is one of my favorite topics to talk about. So we all say eat a heart-healthy diet, and then we get a picture of this plate from the CDC that tells us that we're supposed to eat healthy. And you got to ask the question, what do you do with this when our food looks like this? So the traditional South Asian diet has actually changed quite a bit. with westernization and acculturation. Right? Our food that was traditionally rich in fresh fruits, vegetables, whole grains, cooked fresh without processed fillers, has now become more westernized. And that includes a number of unhealthy fillers and ingredients, such as heavy cream, refined flour, an increase in saturated fats, so using more ghee, coconut oil, palm oil, heavy cream, a number of added sugars, trans fatty acids due to repeated use of oil when deep frying, and then an increased consumption of red meat. So the transformation of the South Asian diet, imposed on which is the addition of traditional Western foods, which also tend to be higher in saturated fats and refined ingredients, really increases that atherogenicity. So I'm going to share with you my experience of walking through an Indian grocery store. My husband is absolutely mortified to take me to the Indian grocery store now, but I challenge you to do this. Walk through the snack aisle, pick up a package of any snack that's available there. The overwhelming majority of those snacks are cooked in palm oil or coconut oil, both of which are extremely high in saturated fats. Many of these oils are available very cheaply and so highly abundant in many of the traditional snacks that are available in the grocery store. And so many of our patients don't even realize that when consuming these things, they're actually consuming a saturated fat that will increase their LDL cholesterol and increase the atherogenicity. So this is a shameless plug for one of our papers that I wrote with my resident Shri and our nationally renowned dietitian Geeta on optimizing dietary patterns and lifestyle to reduce atherosclerotic cardiovascular risk among South Asians. And I'd like to share with you just some of the snippets from this paper. So we put together a table that is informally I refer to as eat this, not that. Right? So how do we take some of these traditional South Asian foods and make them a little bit heart healthier? Right? So a lot of our foods are traditionally made with whole milk, full-fat dairy, heavy cream, cheese, and so a lot of those ingredients can be substituted for non-fat or low-fat milk products. Substituting the higher saturated fats with liquid oil, so corn, soy, olive, sunflower, any non-tropical plant-based oil that's liquid at room temperature. Opting for things that are grilled or baked or boiled instead of fried. This one is my least favorite, white rice and white flour, because that is a huge staple in our diet. But when you think about the carb load from eating a bowl of white rice, a lot of times that is the equivalent of eating a bowl of sugar when it comes to carbs. And so we actually recommend a lot of whole grains such as brown rice, wild rice, oatmeal, ragi, things like that that are that have a little more of the fiber content to it. Trying to avoid some of the deep fried snacks, which are delicious at every party that you go to, and opting for things that are more baked or sautéed. Not reusing cooking oil, because reusing the cooking oil will increase the atherogenicity of the oil. And then preparing desserts with more nuts or sugar substitutes and lower fat milk. So we created, based on the national guidelines, our own sort of dietary plate that matches the traditional South Asian diet of what we think would be the appropriate balance of the nutrients. So I often ask my patients, what do you order off the menu at an Indian restaurant that is heart healthy? And I'm going to pose that same question to you.
Perfect.
All right, so nobody really took me up on that challenge of answering that question, but there was a lot of chatter about it. So it is really hard to eat heart healthy at South Asian restaurants, right? A lot of our food is fried, it's fatty, it's got a lot of oil, a lot of heavy cream, uses fillers. And so while we can never achieve perfection eating at a South Asian restaurant, we did put together in our paper some heart-healthy eating tips when dining out. And this is something that we share with our patients. Try appetizers that are cooked in a tandoor. Try to choose entrees that are prepared without added cream or butter, or try to avoid the fried foods. Trying to choose whole wheat products instead of your refined white flour products. Avoiding foods that are cooked in ghee or butter or coconut oil, and going for those non-tropical liquid oils. Trying to do dessert that's a little more fresh fruit or sugar-free, and then choosing some unsweetened beverages, avoiding additional salt. So we do coach some of our patients on how to make some of these modifications when dining out. All right, let's talk about exercise. So it made me really sad to learn that physical activity levels are the lowest in South Asians overall. And South Asian women were noted to be less physically active than South Asian men. And this is something that we really need to change. An overall higher daily sedentary time is seen among South Asians when compared to other ethnicities. Both physical inactivity and sedentary lifestyle are associated with a higher prevalence of type 2 diabetes, obesity, and increased death from coronary artery disease. But it's not that simple. There's a lot of barriers to exercise that are cultural and that we really need to understand when coaching our patients. First of all, the traditional construct of exercise for self-benefit does not necessarily resonate well with all individuals, and not all South Asian patients really identify with Western forms of exercise. Then we have to think about women and how they feel about exercising in mixed settings, and in some cultures that may be considered inappropriate or make some women uncomfortable. Additionally, there are time and financial barriers and limitations with regards to space to exercise. When we look at the guideline recommendations for physical activity, it's important that we counsel our patients about physical activity during every visit. The guidelines recommend that adults should engage in at least 150 minutes a week of accumulated moderate intensity exercise or 75 minutes a week of vigorous intensity aerobic physical activity to reduce cardiovascular risk. For people who are unable to meet those, it's important to encourage them to do some moderate or vigorous physical activity. And decreasing sedentary time can also help reduce ASCVD risk. So how do we counsel our patients? Culturally tailored recommendations for physical activities may have a little more impact. So recommending things that patients are more likely to identify with, Bollywood dancing, bhangra, cricket, brisk walking, can help improve adherence, especially in middle-aged or older individuals who tend to avoid gyms. And I think it's really important to read the room in this situation. Right, your first generation older patient may not feel comfortable exercising in a gym, but may feel comfortable doing yoga or taking a walk. Your younger generation, patients who are a little bit more westernized and acculturated may feel more comfortable working out in a gym. So it's important to understand what some of those social and cultural barriers are and make individualized recommendations for exercise based on that. Let's talk about some alcohol. So, in general, the average alcohol consumption among South Asians is relatively low compared to other racial and ethnic groups. However, alcohol-related morbidity rates are higher among South Asians than in the general population. And some of our studies have shown that a longer length of residence in the United States is suggestive of greater westernization and has been associated with increased alcohol consumption. So what are the consequences of the alcohol use, right? There are a number of medical conditions that are exacerbated by alcohol use. And many of these conditions, like type 2 diabetes, hypertriglyceridemia, and metabolic syndrome, are conditions that are already highly prevalent among South Asians. So the use of alcohol actually exacerbates these conditions even further and increases the risk. So I'd like to transition to talking about coronary calcium scoring, which is a screening tool that we can use in our patients. So coronary artery calcium scoring may be a useful test to improve risk stratification and guide primary prevention efforts. It is cost-effective, highly reproducible, and a specific marker of subclinical atherosclerosis. And this is, for those of you who aren't familiar with it, a low-dose CT scan of your heart without contrast, that is indicated in patients who are asymptomatic. And so we do a CT scan, we count up how much plaque you have in your coronary arteries, you get a score in terms of units of plaque, and then we take that score and we compare you to other men and women at your age to see where you rank in terms of a percentile. Individuals with either a high coronary calcium score or a high percentile are considered to be at a higher risk. So I want to share with you a short case that we published. This is one of my patients. This is a 43-year-old South Asian gentleman who has a really robust family history of atherosclerotic cardiovascular disease. He didn't have any personal traditional risk factors, never smoked, he was physically active, didn't take any medicines. But his dad had a heart attack at the age of 39 years. And his older brother had an angioplasty with multiple stents at the age of 43. So we put him through the traditional 10-year risk calculator, and it said that he was low risk. But then, knowing that he had this concerning family history, which is considered a risk-enhancing factor based on our guidelines, we opted to do a coronary calcium score on him. And his score actually came out to 137 Agatston units, which put him in the 94th percentile. So this was actually a high-risk gentleman who was thought to be low risk based on the 10-year risk calculator. So one of my other papers, if you're interested, but the coronary calcium score can really help what we say level the playing field when it comes to South Asians who appear to be low risk by traditional risk calculators, and when you take a look inside, that may not necessarily be the case. This is a paper that I published last year in JACC Advances that summarizes the identification and management of cardiovascular disease and its risk factors among South Asians. So take a look. And then, do we have time for me to go through a few more slides? Okay. All right, perfect. So I can just stop right here and take questions. So I'm going to skip through the next few slides. And I would go to my last slide, which shows you that preventing heart disease is truly a way of life. And I encourage you not only to talk to your patients, but also make time for your own wellness. It's the best investment that I've ever made in my lifestyle. So I was never raised to be athletic, but have learned how to incorporate exercise, trained myself to be a runner, never thought I was going to lift weights, and here I am. And so I really encourage all of you to not only optimize your patient's cardiovascular health, but also your own.
That was a great talk, thank you. Besides the lifestyle changes, when we're talking about children, what blood tests would you recommend that we start doing? Should we start checking lipoprotein A's at a younger age? Or is there anything you would suggest so we can try to prevent this starting early on? I mean, the lifestyle, of course, is super important, but I'm just wondering about any blood markers.
Yeah, absolutely. I think that's a great question, and I'm glad that we're actually thinking about kids, right? Because a lot of times when you think about prevention, it's people that are in their 40s, 50s, 60s that are coming in. So I agree that everybody should have a lipoprotein A level checked at least once in their lifetime. Currently, because there's no treatments available pharmacologically for lipoprotein A, the question is, what would you do with that? So I think it's good to know, we encourage our patients to optimize all of their cardiovascular risk factors. We treat their LDL cholesterol. I don't know how much of that would necessarily kind of pharmacologically translate into the pediatric population. However, for my high-risk South Asian patients who've had heart disease at a young age, I make sure to tell them to talk to their kids about eating healthy, exercising, making sure that their numbers are within range, talk to their pediatrician, making sure that they don't have high cholesterol or triglycerides or anything like that. So it's important to start early from that standpoint.
The way you put the slides together, it's amazing. I'm an internist and I speak with all my patients about the prevention. and I got some actually pointers from your talk. I have two questions. I'll keep it simple. One of the questions is you mentioned about animal protein. We know that vegetarian diet doesn't have too much of protein, and whenever you're trying to consume a lot of vegetarian protein, you also get a lot of carbs with it. So there has always been studies about lean protein. So I want to know about your thoughts when we talk about animal protein as lean protein, how good that is. And if that's not the case, then what are your opinions on supplements that are available over the counter for increasing the protein in our diet? Like what you would recommend and what you would want us to stay away from. The second question is about the coronary calcium score you mentioned. It's great when we see calcification above a certain score, especially 100, but the confusion is when the numbers are lower and you're stuck trying to figure out if you have a calcium score of 20 to 50. Now what in the world are we going to do? How am I going to convince my patient? Although we know that there's a soft plaque buildup already happening. So if you can shed a little bit of light on these two topics, that would be great.
Absolutely. I think those are both great questions. Let me start by addressing the coronary calcium score question. Your coronary calcium score not only has a score in Agatston units, but you also have a percentile, right? And so I use that percentile to help guide me. If you are a 40-year-old patient and you have a calcium score of 5, somebody may just look at that and say, well, that's low risk. But actually, if you're 40 years old and you put on that amount of plaque, you're probably up there in the 90s some odd percentile, maybe even the 99th percentile, compared to an 80-year-old with a coronary calcium score of 5. So I think that percentile really helps guide how aggressive you need to be about treatment in terms of, who am I going to initiate on a primary prevention statin and counsel from that standpoint. So I would say look at the percentile and let that help you guide your decision. With regard to protein, I think there's a lot of varying opinions about this, and I'm going to just share mine. In our clinics, we don't force or try to make all of our patients be vegetarian, and we know that patients have different levels of physical activity. And so if they, are not vegetarian, we say, okay, we want you to choose some of the leaner proteins like chicken, fish, and then make sure that they're being prepared in a manner that's healthy. I do think that the traditional South Asian diet, the vegetarian diet, does have opportunities for protein that are sometimes overlooked, right? We've got, a lot of great dals, sprouted grains, things like that. It's just, when you go out to eat at a restaurant, who makes those things? It's all saag paneer and, I don't know, lots of different forms of paneer that are floating in heavy cream. So I think part of it is sort of digging into what our diet has to offer. I do agree that it is high in carbs and fat, and sometimes you do have to kind of find a way to make it higher protein. I had some patients that will supplement with other things that are not in the traditional South Asian diet, but like tofu, egg whites if they want. Some of our athletes do the whey protein powders and things like that. So I think a lot of that can be individualized. One of the things that we do in our clinics is that we have our patients meet with a dietitian. So I've got a South Asian dietitian who meets with our patients, and she can individualize some of those recommendations for them.
Ask one. For that. It is really refreshing to get the culturally appropriate advice on diet and stuff like that. Do you have any comments on inflammation connected to the mouth, the oral systemic connection, and how that can sometimes tip the inflammation towards increasing risks for vascular disease?
That's a really interesting question, and I don't know specifics about that, but I would imagine that foods that increase inflammation will also overall increase inflammation can drive heart disease, right? So there's probably an association there.
We'll try to keep it quick because there's just 1 minute left. But there was some mention of calcium score, a lot of mention of calcium score and soft plants. Do you use CCTAs in your practice, and where do you apply, especially in the South Asian population? And
Yeah.
secondly, go ahead and show the handout that we created.
Okay. All right.
Do we have time for questions? Do we have time for more questions?
Okay. There's a coronary calcium score, and then there's a coronary CT, which is a contrast, higher resolution CT scan. If you go by the book, the coronary calcium score is a low-dose CT scan, lower resolution, not as expensive. It's really designed as a screening tool for patients who are asymptomatic. The coronary CT is much more involved. There's more radiation, you get contrast, you get to view the soft plaque and the calcified plaque as opposed to just the calcified plaque on the calcium score. If you're going by the book, the coronary CT is indicated for patients who are having symptoms. And that's typically what we will use it for. If patients aren't having symptoms, we'll stratify them with a coronary calcium score because it's lower radiation. At that point, you don't really need to know how much soft plaque they have. It's a good prevention tool. Generally, for people with the calcified plaque will correlate reasonably well with the soft plaque. We know that there's some outliers. So on a population level for screening, we always use a calcium score. And then for symptoms, we'll use a coronary CT.
Thank you so much. Because of time constraints, I think we'll move on to the next topic. But Dr. Kulkarni, can you please pull up your slide with your email, so if anybody wants to do that, and if you would, are you going to be there during the coffee break?
Yes, I will.
So please feel free to email her or ask her any questions during the coffee break.